So in this class, we are going to talk about surgical condition of small intestine. So first of them is duodenal atresia. Duodenal atresia. Now, what is this? So this duodenal atresia most commonly occurs at the point of junction of foregut and midgut. Now, where is that junction? Any idea? Where is the junction of between foregut and midgut?
Yes,
Second
sir.
part of duodenum at the ampulla of vital.
Sir, it is below the major duodenal papilla, sir. The papilla vater, of course.
Exactly. It is near to the ampulla of Vater or major duodenal papilla. Absolutely correct. Yes. So that is the junction of foregut and midgut, and there occurs duodenal atresia congenitally. Okay. Now there are some important point I am going to highlight here. There is a different artery for the foregut and midgut. The artery for the foregut is celiac trunk, whereas the artery for the midgut is superior mesenteric artery. So exactly at that site, the branches of the celiac trunk and superior mesenteric artery also separate. And some of the structure like the head of the pancreas can be, perfused by both sides. There are some exceptions there, but other than that, most of the structures which are derived from the foregut are supplied by celiac trunk, and the midgut are supplied by superior mesenteric artery. Now, this condition results in bile-stained vomiting. The reason behind this is mainly the atresia occurs after the opening of common bile duct. Okay, if atresia occurs after the opening of common bile duct, then bile can still flow to that proximal segment. Then when the child vomits, the bile will come in the vomitus. So this is bile stained vomiting, and it always look green in color. Now, what are the clinical features? With congenital duodenal atresia, the common bile duct usually enters proximal to the obstruction, and the vomit therefore contains bile. Just now we talked about that. There may be profuse vomiting, occurs from birth, and the stomach may be visibly distended. Now, whenever a baby is, drinking milk or taking other type of food, especially at birth, the baby can or should only drink milk. That is also mother's milk. If not mother's, then formula or other types of milk. Okay. So what happens? The milk can pass from the stomach to the duodenum, but there is acute obstruction in the second part of the duodenum. There is no connection between the proximal part and the distal part. So there is a gap between that. So the GI tract is discontinued there. Okay, so there will be a back pressure development. There will be collection of the milk. Okay, and then the baby will vomit it out. And because of this obstruction, even the stomach is distended there. And sometimes we can see that distension if it is a massive one. This is a common association with Down syndrome. Trisomy 21 is Down syndrome. And remember, duodenal atresia is very common in Down syndrome. This is listed as one of the problem in Down syndrome baby. So what I'm talking here, by the look itself, you can see a lot of features of Down syndrome in that baby. Like there may be mongoloid face, okay, there may be simian crease, okay, there may be epicanthal fold in the eye. A lot of things would be there. Okay, let's move on. Now, what are the differential diagnosis of duodenal atresia? The differential diagnosis can be esophageal atresia, and in this condition, the baby presents with choking rather than vomiting. Okay. Sometimes it may look a bit similar. What happens in esophageal atresia is there is a blind loop, isn't it? There is no connection with the distal loop. There is a gap. So that loop gets filled up with the milk, and the baby will regurgitate it. And that regurgitation of the milk is almost look like vomiting. That's why esophageal atresia is considered as a differential diagnosis. But it can be easily, separated. How esophageal atresia is diagnosed? Yes, how it is diagnosed? Anyone?
So by passing a rubber into the esophagus, when reach to the atresia part, it will be coiled. And when we take the X-ray, then we can diagnose.
Excellent answer. Very good. Excellent. So this is done by red rubber catheter passage. That red rubber catheter is a radio opaque type of catheter. So after that, we can even take the X-ray, or if you don't want to take X-ray, simple passage of the rubber catheter is also fine. So that rubber catheter will coil there. Okay, it doesn't go distally. It coil there and will come back. So we know there is obstruction, and confirmation is taken by the X-ray after we do this. Excellent. Now, pyloric stenosis is another differential diagnosis. This is even more important differential diagnosis than esophageal atresia because there is profuse vomiting in case of pyloric stenosis. Now, the type of pyloric stenosis in this case is called hypertrophic pyloric stenosis because sometimes at the time of birth, the pyloric sphincter is hypertrophied, and the circular muscle which is present there will give compression or will cause obstruction to the lumen, and this is leading to the obstruction. So this is known as hypertrophic pyloric stenosis. Duodenal atresia is occurring a bit distal to that only, so the clinical feature often matches, but there is one big difference. Pyloric stenosis, vomiting, okay, doesn't have bile in it. Okay, bile is absent from the vomitus because common bile duct opens only in the second part of the duodenum, and here the obstruction lies at the pyloric area. Okay, so everybody can understand that. We can feel or palpate the pyloric tumor. Now, this tumor is not the neoplastic tumor here. This tumor is a mass, and this mass is there because of hypertrophied pyloric sphincter. Onset of vomiting is a bit late, okay, not like duodenal atresia, which occurs right from the birth. It occurs a little bit later, after 2 weeks actually, but more in 3 to 4 weeks. That is the important point. And one more point I like to highlight here is in pyloric stenosis, the stomach, okay, is distended. It is more distended than visible peristalsis will be there. Visible peristalsis. Now, what is the, where is the stomach located in the abdomen? Remember, it is located in the epigastric area, but it is a little bit tilted towards the right hypochondrium. That means the greater curvature of the stomach has a very nice course there. So if I want to see this visible peristalsis, I need to run my eyes through the greater curvature of the stomach. And greater curvature starts relatively from the left side. It passes in the epigastric area and it ends on the right side. It starts from the left side, runs through the epigastric area and ends on the right side. So this peristalsis also moves accordingly. This is the visible peristalsis in case of pyloric stenosis. Another one is congenital intestinal obstruction. So there is abdominal distension. In this case, an abdominal X-ray reveals picture of intestinal obstruction. This occurs usually distal to the duodenal atresia. What investigation you like to do in this type of cases? Okay, try to take a concept of it. This is a just a concept type of thing. Electrolyte and acid-base status should be measured. Now, this baby is profusely vomiting for a relatively longer period of time. It depends when the baby is taken to the hospital. So by that time, the baby is already having electrolyte imbalance. Electrolyte imbalance, especially potassium. Potassium may be low, okay, in this type of cases. And acid-base status measures depends on the dehydration. If dehydration is there, and if hypovolemia is there, then this baby has a high chance of development of metabolic acidosis. Okay, metabolic acidosis. But if it depends on which type of electrolytes are lost in the vomitus. So even metabolic alkalosis can be there if there is a large loss of acid and even the chloride. Now another investigation is plain abdominal X-ray. Okay, plain abdominal X-ray, and in that you will see a very important radiological finding that is known as double bubble sign. This is absolutely important MCQ question in the exam. Double bubble sign. Now, what do you mean by this double bubble sign? See here, one bubble of the air is from the distension of the stomach. Okay, usually in the fundus of the stomach there is air shadow. We all know that, but that air shadow will be much bigger in this case. And another bubble is from the proximal duodenum. Okay, this is known as duodenal cap, or the first part of the duodenum. Usually the atresia lies in the second part of the duodenum, we already talked about, but the first part is still normal. It has got a lumen. So that first part of the duodenal cap is distended with air. So one bubble of the air there, another bubble of the air in the fundus of the stomach. So this is known as double bubble sign. What about the rest of the bowel? Okay, see there, the rest of the bowel doesn't have any gas because there is no continuity of the GI tract. The GI tract is not continuous there. It is acutely ended at the second part of the duodenum. There is a gap and the distal part starts a little later. So there is no gas in the distal part of the bowel. It is collapsed usually. Barium study mesostenosis, but we rarely do barium study in this type of cases. We are afraid of, if there is a huge amount of distension, we are afraid of perforation and things like that. So barium meal, okay, barium, swallow and this type of tests are not routinely done in case of obstruction cases. Now it is a treatment now. Treatment involves the surgical correction via duodenojejunostomy. Duodenojejunostomy with resection of the atretic section. Definitely. Okay. Sometimes there may not be any, a presence of that. There is a gap between a proximal segment and the distal segment. So you don't need to resect anything there. You just need to, do end-to-end anastomosis. So this is the management. Now, the same thing is coming back again. Down syndrome. Don't forget to examine the child completely for the other features of Down syndrome and try to find out what features are there. Like a congenital heart disease is very common in Down syndrome. Which congenital heart disease, by the way, which is the commonest in Down syndrome? Which is that?
Endocardial cushion defect.
Endocardial cushion defect.
Endocardial cushion defect.
Very good. Endocardial cushion defect. ECD or endocardial cushion defect is the commonest one. Okay, don't forget that. It's very important MCQ question in the exam. Many other cardiac anomaly can be there, but this is the commonest, which is mentioned in many different textbooks. Now, small question, okay? I like to discuss like this with my students. If a baby is born with Down syndrome in the family, what type of counseling you want to do? The parents are very worried that another baby may also be born with Down syndrome. So what type of counseling you like to do with the parent? Anyone? Okay, this is a little bit difficult question maybe. Okay, a little
Yes,
bit. Yes, sure.
Like sir, as you know, sir, a Down syndrome baby, like sir, is not a very normal baby. So like sir, baby like this, like sir, like we can give him like sir, like chores around the house, like sir, some work to do. Like sir, we can make him play with other kids, like sir, who might have Down syndrome or who might not have Down syndrome. Sir, we can do things that can like sir, sort of motivate him, and like sir, his intelligence and many other things. So these are the sort of
Okay,
Down syndrome baby.
fine. Now, I agree with his answer, but the point here, what I want to discuss is the parents are very worried that another baby may be born of Down syndrome And he's right. What happens to this baby? Also, they want to know. So it is your job as a doctor to counsel. So this is known as genetic counseling. In this type of congenital problems, okay, or chromosomal abnormalities, we have to provide genetic counseling to the parent. The first thing is you have to sure yourself what is the diagnosis. Okay, that is the first thing. Without diagnosis, you don't know what is the a chance of occurring in the future pregnancy, what is the prognosis, what are the complications. You don't know anything. So first diagnose it, then go to the literature. Okay, go to the literature, try to see the syndrome. There are a lot of books which are about the syndromes in pediatric age group. Just go through that, you solidify or consolidate your knowledge, then you are ready to give counseling to the parent. Okay, just don't you know uh, tell whatever means. If you are not certain, if you are not sure, better not to counsel during that time. You should be ready, because it has a huge implication in the life of that baby. For example, this Down syndrome baby is mentally retarded. We all know that IQ level is very low. Okay, so you cannot say, okay, this baby is just like other baby. This baby is deficient in so many things. But there is a way how to tell that to the parent. You cannot say your baby is useless. Okay, your baby is dumb. Your baby cannot do anything in life. Rather than that, we can say, okay, your baby can go to school, but if other babies are studying, okay, in grade 2 at the age of 6 to 7, your baby will just start to go to school at that time, like that. So they'll understand, yes, there's something wrong in my baby, but that is a very good way of counseling. And another thing, there is a chance that future baby can be of Down syndrome. There are different types of Down syndrome according to the mechanism, like non-disjunction. Okay, non-disjunction is one of them. Then mosaicism is another one. Translocation is the another one. It all depends on that. Okay, so this is a big topic. Whenever there is appropriate time, we can talk like that. Let's move on. Another subtopic under intestinal surgical condition is Meckel's diverticulum. So let's talk about it now. Meckel's diverticulum is a persistence of segment of a vitello-intestinal duct or omphalomesenteric duct, that is another name, which retains its communication with the ileum. Now, this is a embryological structure, okay, vitello-intestinal duct. Now, this vitello-intestinal duct is connecting between the yolk sac and the midgut. Between the yolk sac and the midgut. Now see this, omphalo, okay, mesenteric. Omphalo is yolk sac, mesenteric is the midgut. So this is the way I remember this. So this is a communication in the fetal life. But after the baby is born, there is no use of this. So this has to completely obliterate. Somehow, if it gets persisted, okay, usually the part which is attached to the intestine, if this is persisted, then this is known as Meckel's diverticulum. So if it is larger, okay, than the expected one, then sometimes what happens, it is communicated with the umbilicus. So ileum is communication with umbilicus, and in rare cases of vitello-intestinal duct, okay, there may be fistulation or fistula formation between the ileum and the umbilicus, and it may discharge some content there as well, but that is very rare. Rather than that complete presence of the duct, only the duct which is very near to the ileum, around 2 inches in length, is persisted, and that is known as Meckel's diverticulum. Now, there are certain facts here. This is known as rule of 2, and look at this rule of 2 now. It is situated 2 feet proximal to the ileocecal junction. So this is 1, okay, here is 2 feet. Another one, it is length. It averages 2 inches in length. another 2 for you, and then it is present in 2% of the population. So this is known as rule of 2. 2 feet proximal to the ileocecal junction, 2 feet means 60 centimeter. It averages 2 inches in length, not very long, and it is present in 2% of the population, more commonly in the male. So we don't know who are those people because most of them are asymptomatic. That person can be you, that person can be me. So when we develop symptom, when we go to the hospital, when investigation is done, then we find out, oh yes, this is a case of Meckel's diverticulum. That is the way. Now, one of the important point is it may contain ectopic, pancreatic, or gastric mucosal tissue, or sometimes even both. Usually, the gastric mucosal tissue is present there, and sometimes even pancreatic tissue. Now, what type of cells are present in gastric mucosa? What type of cells?
Parietal cells,
Right, it says
enterochromaffin cells.
Very good. Parietal cells, okay, chief cells, and some cells known as enterochromaffin cells. Parietal cells, okay, chief cells, and some other cells like enterochromaffin cells. They are responsible for the secretion of other GI hormones like gastrin, okay, things like that. Now, parietal cells are responsible for the secretion of hydrochloric acid, HCl, and intrinsic factor. Let's not talk about intrinsic factor now. This is not important here, but HCl is very important. That HCl, it cannot be neutralized because there is no source of any bicarbonate there. There is no pancreatic juice coming or any other thing. So it cannot be neutralized. Having said that, it can burn the mucosa there, and it can result in hemorrhage or bleeding, and it can result in pain as well. So this is the most important problem in case of Meckel's diverticulum. Let's move on. Now see here, there is one picture which I have collected. Here is the stomach, here is the duodenum. Okay, after that there's a small intestine. Okay, small intestine, there's a jejunum, and after that ileum. So it is present in the ileum because it is just 2 feet proximal to the ileocecal junction. This is ileocecal junction right here, 2 feet proximal, and here is a Meckel's diverticulum. Okay, it is present in anti-mesenteric border. For example, here on this side, there is attachment of the mesentery. Mesentery is a fold of peritoneum which is supporting small intestine. So it is present on the other side of that is anti-mesenteric border. See this. So this exactly looks like this. What are the clinical features of Meckel's diverticulum? Usually the condition is asymptomatic. The person is having it, but they don't have any sign and symptom. Occasionally, okay, the diverticulum becomes inflamed. The diverticulum becomes inflamed and presents with features of inflammation which are similar to acute appendicitis, almost similar. Remember, the site is also very near to each other. Okay, just 2 feet proximal and 2 feet distal. So it may present with acute abdomen, acute abdominal pain there. So we are often confused this with acute appendicitis. And many of the time, the surgeon also confuses this with appendicitis, taken the patient to the operation theater, open the abdomen, and they will be very surprised to see that appendix is normal. But they will never panic because they have not done anything wrong. Okay, what they do now, they will take that lumen, that loop of the intestine out from the incision area. Okay, now they will exactly go about 2 feet proximal till that loop. They will pull it out, and they look for Meckel's diverticulum in each and every case of appendicectomy. If there is Meckel's diverticulum present, they will resect it. There is no point keeping that Meckel's diverticulum there, because who knows, in the future it may cause problem to the patient. So both surgeries are done at the same time, Even if the appendix is normal, they will remove it, appendectomy, and even if there is a Meckel's diverticulum, they will remove it. Even if it is inflamed or not, the surgeon don't care. So this is the important point to know. Perforation results in local or generalized peritonitis. Now, sometimes perforation can happen there because of that hydrochloric acid, there is inflammation occurring, and that inflammation can result in perforation. Now, whatever is the content of the GI tract, it may leak outside through that perforated site, and it can lead to local peritonitis in the beginning, and later on generalized peritonitis. Now, every student know what are the feature of this. Okay, first is abdominal pain, maybe local, later on general. Second, guarding and rigidity of the abdomen, guarding and rigidity. Third, absence of the bowel sound. Now, when you try to hear the bowel sound, they are absent because there will be paralytic ileus development in case of peritonitis. And still later on, there is distension of the abdomen, okay, because of the fluid collection in the peritoneal cavity and collection of the gas in the intestine as well. So all these are features of peritonitis. Let's move on. Now, let's have a look at this picture here. Okay, this is a real picture, a real, Meckel's diverticulum from a patient. See this? This is the ileum. Okay, ileum. What is this yellow structure here? What is this? Quickly, what is this?
Mesentery, sir.
Very good, excellent. This is the mesentery. This is the mesentery, which is supporting, okay, supporting the small intestine. It has a lot of fat in it, okay, but this is actually the fold of peritoneum. Now, see this. This is called anti-mesenteric border, the opposite, and this is a Meckel's diverticulum. Meckel's diverticulum. Now, some other clinical features of Meckel's diverticulum are sometimes the Meckel's diverticulum presents as an intussusception or a volvulus. Now, why intussusception is present here? Because this Meckel's diverticulum, especially if it is inflamed, sometimes it may act as a inciting site for intussusception. From there, the bowel goes distally, and it is telescoping into the distal segment. This is known as intussusception. Volvulus means twisting of the bowel there. The clinical features may be those of an intermittent right-sided abdominal mass with associated pain. Now, another important point here, Meckel's diverticulum may also contain ectopic gastric mucosa. We have already talked about this, which results in peptic ulceration, and this results in hemorrhage or perforation. Now, listen carefully for this question. What type of blood will come out in the stool if there is bleeding from the Meckel's diverticulum? Yes?
Sir, maroon colors and red
Melena,
colors.
Melena, it is called Melena, sir.
Okay, so it is maroon colored or melena. Anybody else? Any other student?
Sir, maybe fresh blood, melena,
Melena.
black stool from the upper GI bleeding. Sir.
Rectal bleeding.
Okay, now see there. So different answers are coming. Some students are saying melena, some are saying relatively a bit darker colored blood, that is called maroon colored, and some even say fresh colored blood. All of the answers are correct, but you need proper explanation there. And the explanation is, if a massive amount of bleeding is occurring, it cannot, the acid which is there cannot turn or change all that amount of blood, okay, because of the quick intestinal transit. Even fresh blood can come out in the stool. That is one explanation. It is almost like massive upper GI hemorrhage. But more commonly, because of the acid which is present there, if a slight amount of bleeding is there, that acid will convert that blood into acid hematine, and it will cause melena. It will cause melena. And then another is also there. If acid is not produced, for example, if acid is produced in a very less amount and bleeding is relatively more than that, then even the maroon colored blood may come there. It's all about the relative thing, which is more, which is less. So this is what understanding is all about. Okay, so don't totally ignore if a person comes with acute red colored blood, fresh colored blood, and don't say it cannot be a case of Meckel's diverticulum. You are right, the chances are less, but you cannot rule it out simply because of the color of the blood in the stool. Ulceration may cause pain around the umbilical area that is related to meal. This is all about increased acid secretion again. Now, we are moving to the important part, that is investigation. How do we diagnose this? Most frequently, a Meckel's diverticulum is asymptomatic, and it is diagnosed commonly at operation. That is, if presenting in a similar manner to acute appendicitis. Just now I explained this to you. Okay, sometimes the surgeon opens the abdomen thinking it is a acute appendicitis. Okay, many of the time that abdominal pain is caused by Meckel's diverticulitis, and it is found out at the time of surgery, and then it is removed. Radiographically, Meckel's diverticuli are difficult to diagnose when symptomatic because of edema around the opening into the intestinal lumen. This may prevent contrast entering the diverticulum. What is the meaning of this? For example, we have done barium meal and follow through. This we call it barium meal, okay, and follow through. This is a type of barium study we do for the small intestine. Now, if we do that, for example, if we want to diagnose this Meckel's diverticulum, but if there is an active inflammation going on in the Meckel's diverticulum area, so because of the edema, there is a swelling, the lumen is narrow, so this barium cannot enter into the diverticulum, then we cannot see anything. So it looks normal. So that type of result may be there. So radiographically, this contrast study is not commonly done. If bleeding is occurring from an ectopic gastric mucosal site, a 99M technetium scan may localize this. So this is one of the important study which is done in Meckel's diverticulum. This is known as radioisotope scan. Okay, 99M technetium scan can be done, and even a very small amount of bleeding can be diagnosed by this, because these are done by radio labeled RBCs. So technetium M scan is labeled in the RBC. Okay, then those RBCs are leaked outside from the very small amount of blood also, and that can be easily seen by the X-ray. There is special type of X-ray, okay, taken by gamma camera, we say. Let's move on. Now, what is the treatment? Diverticulectomy is the treatment here. Diverticulectomy is a removal or excision of diverticulum. This is indicated if there is inflammation, ulceration, perforation, or a narrow neck. So these all are indication for diverticulectomy. Or I want to add one more sentence here. If we have opened the peritoneal cavity for something else, but accidentally or incidentally, if there is presence of Meckel's diverticulum, during that time also we remove it, because there is no use of this. It involves the ligation of omphallomesenteric artery and the vein, and the removal of a portion of adjacent ileum, which may also contain ectopic gastric mucosa. So this is one important point we need to remember. Not only the diverticulum, but a part of or a portion of the adjacent ileum is also sacrificed here, because if we leave that part, then because of this ectopic gastric mucosa which are present there, it may continue to bleed later on, even after the surgery. So make sure you resect a small part of the ileum on both sides, and then end-to-end anastomosis has to be done. Now, these are the complications: diverticulitis, bleeding, and obstruction. Diverticulitis, already talked about, presents in the similar way to acute appendicitis. It is uncommon in children under 10 years of age, and probably it takes time for the production of that acid and things like that, and it is diagnosed at laparotomy. Okay, so this is about diverticulitis. Treatment is diverticulectomy. Bleeding, already discussed. Bleeding is because of this ectopic presence of the gastric mucosa there, okay, which is known as heterotopic gastric mucosa, and it may be detected easily by 99M technetium scan. 99M technetium scan. This is a radioisotope material. And the third type of complication is obstruction. That can have in the form of intussusception. Now, that Meckel's diverticulum, may start the intussusception process. That is the meaning. It may cause obstruction in the form of volvulus. That part may twist around one particular axis, and volvulus is a very serious type of problem because it leads to ischemia and necrosis of the bowel. And then there may be persistence of the vitello-intestinal band. Okay, vitello-intestinal band. That is, there may not be any, for example, complete type of diverticulum till umbilicus, but from the apex of the Meckel's diverticulum, one fibrotic band may start and it may end up to the umbilicus. Now that band may act like a obstruction site. Sometimes what happens, intestine may lie against that band, and it may cause obstruction. This is known as vitello-intestinal band. Okay, almost like adhesions and the band, which we'll talk again when we enter into the topic of intestinal obstruction. So this band can act as one of the cause of intestinal obstruction. So these are some of the common complications of Meckel's diverticulum. Very important question from the exam point of view. Now, regarding the complications of Meckel's diverticulum, if they ask you this question, then don't forget to mention one more complication that is known as Litter's hernia. Okay, Litter's hernia. This Litter's hernia is an intestinal herniation which mainly occurs from the inguinal region, and the content of this herniation is Meckel's diverticulum. Okay, that is known as Litter's hernia. If the content is Meckel's diverticulum, we call it Litter's hernia. Apart from this, all other things we have included in our discussion. Okay, and very rarely neoplasm can also develop from Meckel's diverticulum, especially a smooth muscle malignancy, which is known as leiomyosarcoma. Carcinoid, which type of substance is secreted by carcinoid tumor? Yes, which substance?
Serotonin, sir.
Serotonin, sir.
Serotonin, sir.
Very good. Serotonin. Excellent. Serotonin. So just like appendix, this Meckel's diverticulum can be the source of carcinoid tumor, and later on this carcinoid tumor may metastasize to the liver. Okay, so it can cause serotonin syndrome or carcinoid syndrome, and some very rare maybe melanoma or adenocarcinoma. Okay, so at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.